Hello, sir. We are good to go.
Yeah. Good evening, everyone. I am Mayank Gupta from Rare Disease team. Warm welcome to all the speaker and participants. As we know, following Pfizer long tradition in promoting science and providing a platform for interactive and insightful discussion, it gives me great pleasure to invite you to attend this continuous medical educational programs. Once again, warm welcome to our all three eminent QLs. And today meeting, we will cover three important topics. First is overview of short stature in India by Dr. Hari Mangtani, clinical spectrum of short stature by Dr. Dasaki Rustagi, and case-based approach in SGA children by Dr. Hemchand. And after that, Q&A session by all three speakers. So our first moderator is Dr. Hari Mangtani. So he is a renowned pediatric consultant endocrinologist. He has done MBBS from Nagpur, then DCH from Wadia Hospital, Pune in 2008. After that, DNB in pediatrics from Jahangir Hospital, Pune in 2010. Then he did training and fellowship in pediatric endocrinology from Bharati Vidyapeeth University in 2012. Then ICMR course in medical genetics and genetic counseling at Department of Medical Genetics, SGPGI, Lucknow in 2018. Then fellowship in pediatric endocrinology from Liverpool, UK. Now he is practicing as a consultant pediatric endocrinologist in Pearl Clinic, Nagpur. So without wasting more time, I would like to invite Dr. Hari Mangtani and hand over today's session to sir. Welcome, sir.
Yeah, thank you so much for inviting me on this platform and giving me this opportunity to interact. Without wasting time, I'll quickly start with my presentation. And so now you can see this presentation, overview of short stature. So shall I start?
Yes, sir.
You are able to see this. Okay. So what I'm going to do in the next 10 minutes is give you an overview of short stature, and these are my necessary disclaimer. What we are going to discuss is something about the epidemiology and pathophysiology of short stature, and simultaneously we'll understand what are the factors that affect growth. The most important things which we are supposed to do in our OPD are growth measurements and the basic investigations which we are supposed to do in patients of short stature, and quickly go through the approach algorithm. If time permits, we'll talk about the management and growth hormone along with the role of growth hormone and so on. So what is the epidemiology and definition of short stature? So short stature is defined as a height which is less than 2 or more standard deviations below the mean for age, gender, and compared to the population. So these three things are very important when we are considering, because it's a comparative variable stature. So we have to compare. Once we have taken the height of a child, we have to compare it with the age matched, gender matched, and population matched data. And when we see in developing countries, short stature is often a consequence of malnutrition, which is different in developed countries, in which we get genetic short stature, or we get endocrine short stature more often. So in India, as we are developing nations and most of our population is in the rural area, we get malnutrition as a major cause of short stature. Now, when we see the prevalence, there have been few studies which have been published, and they have actually seen the number of cases who are attending their OPD and divided them based on the diagnosis, and it was found out that PEM and chronic diseases, it constituted more than 50% of the cases of short stature who have attended the OPD. However, the endocrine problems, the patients who were short with endocrine problems were almost nearing only 5%. So we can see the burden is almost 10 times when we consider nutrition. Around 10% or so will have a physiological cause of short stature depending on from where they are belonging to. Mostly constitutional delay in growth and puberty, which is rare in girls, is seen more commonly when they are coming from the rural part. And while from those coming from urban areas and well secured nutrition as well as the social security is there, they are more prone to get precocious puberty rather than constitutional delay. However, the incidence of constitutional delay in males has remained almost same in rural as well as urban population. Now, factors, what are the factors that affect growth? What are the things we should keep in mind when we are thinking about growth of a child? So the first and foremost, I would go with absence of a chronic disorder. A chronic infectious disease or an organic disease which is there inside, undiagnosed and untreated, will present a short stature. Sometimes we have seen that a chronic kidney failure or most importantly gastrointestinal disorder like celiac disease, they have presented as short stature, and later on the workup has suggested that the child is suffering from celiac disease, or sometimes it is anemia, a chronic long-standing untreated anemia which has led to growth failure. Similarly, we have to screen all the systems like hepatic system, the renal, cardiac, pulmonary system, a prolonged untreated asthma, or if we have obstructive apnea or adenoiditis, chronic adenoid hyperplasia, that has led to growth failure. And once they undergo surgery, adenectomy is done, then they start growing. So we have got hematological causes, metabolic causes, and we have got other central nervous system causes like idiopathic cerebral palsy and all, which can lead to growth failure, including rheumatological cause of chronic juvenile arthritis. So these are all known cause of short stature, and absence of these is a must for normal growth. So chronic infectious disease, malnutrition, and organic diseases, these are to be first in the differentials when we come across a patient of short stature. Now, when we talk about small for gestational age, Hemchand will be talking about this in detail, but small for gestational age is kids, those who are at birth. So this is a definition applied to kids at the time of birth if their length or weight is less than 2 standard deviation. 2.5 standard deviation below the for gestational age are considered as small for gestational age. When we talk about idiopathic short stature, we have got normal variants. Normal variants is only constitutional delay in growth and puberty. However, familial short stature is no longer considered as a normal variant, as both the parents who are short might be suffering from some or the other kind of a skeletal dysplasia or a very minor variety of a genetic disorder of responsiveness of growth plate to the circulating growth hormone. So this could be a cause of familial short stature. But constitutional delay in growth and puberty, they are healthy subjects, but with they mature late in their life. They are short till say 6 or 7 standard, and then they pick up their height and become taller as the puberty progresses. So these are important causes. Along with this, we should consider genetic causes. Turner syndrome is one of a very important cause of short stature in girls. So that has to be kept in back of the mind. And yes, we have got unknown causes also, for which we classify them into idiopathic short stature, where they demonstrate a normal growth velocity, but they are short for the family. Endocrine diseases, again, hypothyroidism is a very common cause, undiagnosed, followed by, I think, growth hormone deficiency or IGF-1 insensitivity or Cushing's. Then we have got rickets, which are a very prominent cause when we are talking about a chronic malnourished child. And a poorly controlled diabetes will also present as short stature. Precocious puberty initially will be taller, but later on they end up as short kids because of the early fusion of the epiphysis. Now, psychosocial, which is short stature, is considered less prevalent in India, but there are not many studies which have consider this as a major cause, but yes, broken families or unhealthy social environment leads to growth failure in such kids. So growth measurement, this is a very important thing which every pediatrician is expected to do in their OPD. I know they are very busy, but at least those parents who are actually concerned about the growth of the child or height of the child, for them at least they should be measuring the growth, and it has to be measured by an infantometer if the child is less than 2 years of age, where the length of the child is measured, or in a stadiometer when the child is more than 2 years of age, and they should be measured in a correctly calibrated in a correct manner, and the height as well as weight along with head circumference up to 5 years of age should be noted down. So once we note it down, we need to know the parental, mid-parental height and the genetic target of that particular child. And there are formulas which help us calculate the target or mid-parental height of the child. For girls, it is the parents' height averaged minus 6.5 centimeters, and for boys it is parents' height averaged plus 6.5 centimeter for boys. That constitutes the target, and this is how we can calculate the target height. Growth velocity, yes, we should know the growth velocity. If we have got previous readings, then we should know this is how we can find out the speed at which the child is growing. And if we are not using this growth velocity curves or growth velocity charts, then also we should know at least this thing, that from birth to 12 months a child on an average grows 25 centimeters during the first year. From 12 months to 2 years of age, the child grows almost 12 to 13 centimeters, and from there onwards, the growth velocity or the speed of growth, it reduces to up to 4 to 5 years of age, where afterwards, till the onset of puberty, a child grows almost 5 centimeters. So any growth velocity or 2 points we have calculated or we know the height of the child which was 6 months back, and now if we calculate it, if the growth velocity is less than 5 centimeters in a year, then it suggests a growth failure, and that warrants evaluation at first go. And during puberty, girls, they grow around 8 to 12 centimeters, and boys, they grow almost 10 to 14 centimeters. So this is the final height which is getting, which they achieve at the time of puberty. Now, how do we assess a child of short stature? We have to have accurate measurements. We have to check for body proportion, which is very important. Once we have to check upper segment and lower segment ratio. And if the body, if the child is disproportionately short, then it points towards presence of a underlying skeletal dysplasia. And otherwise, if the child is proportionately short, then we have to rule out other causes of short stature. Assessment of height velocity we have discussed, and we have to compare it with the population norms. So for population comparing it, we have got growth charts. In the Indian Academy of Pediatrics in 2015 has published growth charts for boys and girls from 5 to 18 years, and the WHO charts are considered are to be used from 0 to 5 years of age. So these are the growth charts. There are two different types of growth charts. For boys, it is blue, and for girls, it is pink. So what are the clinical pointers? So during a clinical examination, one should look for anterior fontanelle or presence of stigmas of achondroplasia or hypothyroidism. One can also look into the faces which in growth hormone deficiency, they are doll-like faces, immature faces, and hypothyroidism, there will be dry skin. The faces also are considered abnormal in Turner syndrome and some dysmorphic syndromes of skeletal dysplasia. One should also examine the teeth for dentition, and hypothyroidism and growth hormone deficiency will also have delayed eruption and delayed falling of milk teeth, and defective enamel is seen in MPS, rickets, and hypoparathyroidism. One should check for stigmas of Turner syndrome like web neck or shield-like chest or presence or absence of goiter. Similarly, dry skin for hypothyroidism or Cushing's triad or some birthmarks if they are present. For limbs, one should check for deformities or stigmas for skeletal dysplasia or rickets. And one should always check genitalia for knowing the sexual maturity rating and how the genitalia has developed. So SMR staging is one thing which every pediatrician should not skip when we are discussing or when we are talking about cause of short stature. Similarly, one should have a cursory or a systemic examination to know all the systems, including anemia, like pallor, icterus, cyanosis, presence of a heart murmur, asthma. All these things are to be checked in, looked into. So that we are not missing on any of the chronic disorders which could be the cause of short stature. So what are the current investigations which we are, this is the algorithm actually, which is required or which is used for evaluation of short stature. Once we have checked the height and calculated the mid-parental height, we should look for any symptoms, obvious symptoms of chronic disorder or any specific sign pointing towards endocrine cause. If it is there, we should go directly for those investigations. And if the symptoms are not there, patient is only short, then we look for dysmorphism. If there is dysmorphic facial features, then we should check the proportionate, whether the child is proportionate or disproportionate short stature. If it is proportionate short stature, we evaluate for genetic syndromes like Turner's or Down syndrome. If the child is disproportionate, then we evaluate for skeletal dysplasia. Now, if the patient is normal looking, non-dysmorphic, we should always see or assess the growth velocity and also look for bone age. And if we find that growth velocity is more than 5 centimeters per year and bone age is slightly delayed, we can actually wait because this child is more probably a constitutional delay in growth and puberty. Similarly, if the growth velocity is more than 5 centimeters and the bone age is not delayed, and the child is falling between the percentiles of the genetic potential, that is more likely idiopathic short stature or familial short stature variety. But when we find that the growth velocity is less than 5 centimeter per year, that means growth failure is there along with delayed bone age. And the weight is relatively preserved when compared to the height age, then one should consider endocrine disorder as a underlying cause for short stature. These are the basic investigation one is expected to do: a urea, creat, electrolyte, blood gas, full blood count, calcium phosphate, alkaline phosphatase, urine function test, kidney function test or liver function test, stool analysis also. The basic investigation are X-rays for skeletal age as well as skeletal survey for suspected skeletal dysplasia, a karyotype or chromosomal analysis for Turner syndrome. So it's ruling out celiac disease, we have got anti-gliadin antibody or anti-endomycin antibody. Thyroid function test to know the status of thyroid, because that is a investigation which every short stature or a child with short stature should have. Special investigation like MRI or growth hormone provocation test are to be left only when we have ruled out the common causes of short stature. With this overview, I would like to tell you the indications for referral to a pediatric endocrinologist. That a child with intrauterine growth retardation or SGA who do not catch up to the growth curve by 2 years of age should be referred. A height more than 3 standard deviation below the mean for age should be sent to a pediatric endocrinologist for evaluation. Or if the growth velocity is less than 5 centimeter or 2 inches per year, all these should be referred to pediatric endocrinologist. If a girl child or not entering puberty by 13 years of age, or there are no pubertal changes in the 14-year age in boys. Similarly, when the projected height is more than 2 standard deviations below the mid-parental height, should also be evaluated by a growth specialist. If someone does a bone age, and if the bone age is more than 2 standard deviation below the chronological age, or if the diagnosis we have come across a diagnosis, you have diagnosed a condition which can be treated by growth hormone therapy. These all patients should be sent or referred to a pediatric endocrinologist or growth specialist. If I have time, I'll go to the management of short stature. Otherwise, I think this overview would suffice. I think my 10 minutes are over. Hello?
Yes. Now we will proceed for the second session. Now I invite to Dr. Vaisakhi Rastogi. She will take a clinical spectrum of short stature. And about Dr. Vaisakhi Rastogi, she has done MBBS and MD Pediatrics from Mumbai. After that, postdoctoral clinical fellowship in pediatric endocrinology from Bharati Vidyapeeth University, Pune. Then she did clinical training at Children's Hospital of USA. Then international scholarship program at Nationwide Children's Hospital, Columbus, USA. Now she is practicing as a consultant pediatric endocrinologist in Prabhuveda Clinic, Pitampura, Akash Hospital, Dwarka, Max Hospital, Shalimar Bagh, and Purple. So now I would like to invite Dr. Vaisakhi Rastogi, and please take.
Thank you, Mr. Mayank.
Welcome.
First, I will share the screen and then. Okay. So, good evening, everybody, and thank you for joining on a weekday evening. I know it's tough for everyone, but I'll try to make it as simple and lucid as possible. As Dr. Hari has already introduced us to the basics of short stature and what all we are supposed to see, I am going to cover up the common clinical cases that we generally get in clinics and how we can go ahead with them and reach a diagnosis. So I'm just going to cover the clinical spectrum of short stature in today's talk. Make it full screen. So Dr. Hari has already briefed us with the types of growth charts. So I'm just going to brush up in a minute with those growth charts. So basically the x-axis has the age in years, y-axis has the height in centimeters and weight in kilograms. And on the BMI chart, the y-axis has the BMI in kg per meter square. The background of the chart is in the form of a grid, and pink is universally for girls and blue is for boys. Now, if you see, this is the growth chart for boys, and there are 7 percentile lines. So this is the third percentile, the last line, and this is the 97 percentile for height. Similarly, this is the weight graph on the lower side. This is the 3rd percentile for weight, and this is the 97th percentile for weight. This is the pink chart, which is for girls. So as Dr. Hari mentioned, that these growth charts are sex specific and country specific. So it is important that we plot our children on Indian growth charts so that we can assess the burden of short stature properly. These are the BMI charts. So BMI charts are generally just behind the height and the weight chart. So it becomes easy to keep them in the files and plot them every time that the child comes to us. So the orange line corresponds with the 23 adult equivalent, and the red line corresponds with the 27 adult equivalent. So above the orange line means that the child is overweight, and above the 27 means the child is obese. So this is the BMI chart for girls. So now with this basics, basic information about growth charts and short stature, we move to the clinical cases. So this is a boy who came to me for short stature at the age of 16. Who came to me at the age of 13 years. Now, this boy was just 132 centimeters tall, and he already had started developing secondary sexual characters in the form of mustache, and his voice has started becoming hoarse. So now the parents started getting worried that still the child is not growing, and he was the shortest in class. In fact, really short. He was just 132 centimeters tall. So this child was a typical case of growth hormone deficiency, isolated growth hormone deficiency. But the problem was that at the age of 7 or 8 years, they had visited a pediatric endocrinologist, and that time also a growth hormone stimulation was done on him, and he was diagnosed a growth hormone deficient child. But the patients were reluctant about taking treatment, and they thought that with time he would grow. So now the problem with this child, why I'm bringing this case in front of all of you and why I'm discussing this case with you, is the importance of bringing and treating these children on time is very crucial in treatment of short stature, because that is one of the biggest factors which determines the adult predicted height or the final height that the child is going to attain. Now, this child came to me at 13, and he was 132 centimeters tall, and his bone age was also 13. So he really did not, his bone age was more than 13, because he had already started developing all the secondary sexual characters, and his tanner was full grown adult. Okay, so now the problem with this child was there was not enough time for us, even if now the parents are ready to give him therapy. However, since the bone age was less than 15 years, we did start him on growth hormone therapy. But of course, now the prognosis is guarded in terms of attaining good final height. So this photograph is, you all can appreciate that he has started developing a mustache, and the typical growth hormone deficient facies that he had. So he was here on the growth chart, so way below the 3rd percentile. Now, this is another child who was brought to me at the age of 3 years with short stature. So here the parents were very alert, and they realized that since the age of 8 to 10 months, the child was faltering on the centiles. And the pediatrician, after the age of 3 years, realized that the child was below the 3rd centile and referred the child to me. Now, on examination, he was on all auxiological criteria, he was fitting into the criteria of significant short stature. He was below 2 standard deviations and below the 3rd percentile. On examination, he had typical cherubic facies and all features fitting into growth hormone deficiency. We did a growth hormone stimulation test, and that came out to be positive. Now, the importance of bringing this child on time is in the first year. Now he's completed 1 year, 6 months of therapy. In the first year of therapy, he has grown 12 centimeters. Okay, so this is the first visit, and he was here on the first visit. Okay, and after 1 year of therapy, now almost he's completed 1.5 years, but at 1 year of therapy, he had grown 12 centimeters from the first consultation. So this is his original growth chart. And if you all can appreciate, this is the time where we started him on growth hormone, and his bone age was 1 year delayed. And now in 1 year, he's almost about to reach the 3rd percentile. So the importance of giving growth hormone therapy on time or treating short stature on time is that now this child will attain a good final height, because the parents know that he's responding to therapy and they are ready to continue with therapy, because they are alert parents, and if you convince them well, they are ready to continue therapy for a long time. This is another patient with growth hormone deficiency. So this incidentally came to me. The boy was brought for short stature. The younger brother was brought to me for short stature. And this is how on history taking, it is important that we take a detailed history of the siblings also. And they also said that on history that the sibling was also small. But however, because it was a girl child, they were not really too concerned about that, but they had brought the younger son to me for short stature. So when the younger son came out to be growth hormone deficient, and this girl was brought just along with the son to just see whether this girl is also doing well, or even she's growth hormone deficient. So in fact, she was also a growth hormone deficient child. So this was genetic growth hormone deficiency. where both the siblings were growth hormone deficient. He's the younger brother who was first diagnosed, followed by this elder sister. So this is where he was at the age of 6 years. He was way below the third percentile. He was only about 85 centimeters tall at the age of 6 years. Now, this is another interesting case. One boy brought to me for short stature. So importance of clinical examination comes in this case, where so the previous case was the importance of the first case was the importance of bringing children with short stature and intervention on time. The second case, the importance was on detailed history taking and family history. This case highlights the importance of clinical examination. So this child was brought to me with short stature, and on general examination, I found that he had a lot of cafe au lait spots. So the mother and the father had come to me along with this child, and the mother had a lot of neurofibromas on the body. So she had actually never even got diagnosed with neurofibromatosis, and she had no complaints with those lesions. So I suspected that this child could have neurofibromatosis type 1, and he had multiple lesions. So see, this was on the front side, those were on the back, and if you all can appreciate, even on the face, he had cafe au lait spots on the chin, and there were many on the face, hands, legs, buttocks. So I did a growth hormone deficiency test on him because he was fitting into the auxological criteria, and he came out to be a growth hormone deficient child with significantly reduced IGF-1. IGF-1 was less than 20. And then to finish our homework before putting the child on growth hormone therapy, I got an MRI done to take the clearance for any intra neural pathologies, and he came out to be a neurofibromatosis case. So this is the MRI report where they have shown that the pituitary gland was normal and there was no lesion within the pituitary on the MRI, but there were multiple neurofibromas in the bilateral cerebral peduncles, in the posterior thalami, globus pallidum, posterior medulla. So here, even though this child is growth hormone deficient, actually we cannot really offer growth hormone therapy to this child because if these lesions ever start growing and there is an raised intracranial pressure or any cranial nerve palsy, then that can be attributed to growth hormone. So this is not an FDA approved indication to be given in neurofibromatosis. Now, this is another case. This child was from Bihar and he was brought to me for poor growth. Before this, he was actually referred to me by the neurosurgeon. So he had hydrocephalus, he had aqueductal stenosis, which was not diagnosed till the age of 1.5 years. And then after that, the neurosurgeon did a shunting, and because of poor growth, then he was referred to me once the shunt was functional. So he was completely, he's all pituitary hormone deficient on evaluation, and now he's on all replacements. He's doing well. In between, he had a shunt blockage, so again the intracranial pressure had risen, so we had stopped the growth hormone for 15 to 20 days till the shunt revision was done. But again, he's back on therapy and he's growing well on growth hormone therapy. So he was, this boy was here. So he was brought at 1.5 years of age when he got diagnosed with hydrocephalus, and in a month's time after getting him operated, they saw me. So the highlights are any child who is below the third percentile with a delayed bone age and with any focal neurological deficit, you should never ignore and rule out all neurological cases. You could pick up craniopharyngiomas, you could pick up neurofibromatosis and many other conditions if you look for neurological features in children with short stature. Any short stature with immature facies and delayed bone age, you should think of growth hormone deficiency, like how we had 2-3 cases which were typical facies with immature facies, cherubic facies, and they typically get compliments that it look smaller than age. So adults getting these compliments is good, but when children get these compliments, it points out towards any organic cause of short stature. Now, this is a girl who was brought to me at the age of 12 years with significant short stature, and other complaints were dry skin and sluggish activities. She was very good in studies. She was a topper in her class, but only problem, and there were no pubertal signs. So this was a very, very typical case of hypothyroidism, and and just picked up by getting a thyroid function test and antibodies. So she was a Hashimoto's thyroiditis. But here the problem does not get over, because the minute you start putting these children on treatment, what happens is their bone age jumps much faster than their height age. And as a result, their predicted adult height gets affected and they remain short adults. So whenever these long-standing hypothyroid children are treated with thyroxine, we should keep monitoring their bone age, and that's why the role of an endocrinologist comes here, because it's very easy to treat hypothyroidism. That is not a problem at all. Pediatricians can manage that very well. But behind that, what's happening is that the bone age is jumping at a much faster rate than the age of the child, and the velocity also increases. So it gives a false hope to the pediatrician also that the child is doing so well. So the child is going to end up very tall and as per the mid-parental height. But this is often a myth, and many a times these children do not reach their mid-parental range. Even the lower side, they do not reach there. So this girl was brought to me at 13, and see where she is. So she's way, way below the third percentile. And definitely any child who is below the third percentile, you always have to suspect organic causes. And without investigating and evaluating, we cannot send them back. Now, this is typically what I was trying to point out. So this is one of the cases from Max Hospital. So this girl is now under my follow-up since the past 7 years. And she had come to me at about 8, 9 years with severe, she had hypothyroidism at that time. And it was a plain Hashimoto's hypothyroidism. So this, even I have learned over time, actually, with experience, that I started the child on therapy. And for 1 year, if you all see, this child was on therapy, and the bone age was at the beginning of therapy, the bone age was only 3 years when she came to me. Okay, and she was almost 9 years old when she came to me. So obviously that delayed bone age was attributed to hypothyroidism, and then I put her on treatment. Now, after 1 year, when I got her bone age done, her bone age had jumped to 9 years. So in 1 year of therapy, her bone age had jumped by 6 years. And then what happened? She had also had a very good growth velocity at that time. So that would actually kind of, hide the reality from us that the bone age was also jumping behind at this great speed. Then at that time, I predicted her adult height, and that was, if this was the speed, the way the bone age was jumping, then it would become a real problem in achieving a good final height, because she was already compromised for 5 to 6 years because of Hashimoto's hypothyroidism. So then I decided to put her on growth hormone therapy along with the thyroid therapy. However, she had not achieved any signs of puberty till last 3 months. So now at the age of 13 years, she has started developing breast budding, and now she's in Tanner stage 3. Okay, but by then she has now almost reached a height of 138 centimeters with growth hormone therapy, and she's taking growth hormone therapy since the past 3 years now. So this is where I wanted to highlight that whenever we are treating hypothyroid, chronic hypothyroid children, we should always continue keeping a check on their puberty and the bone age. Now, this is a girl brought to me at the age of 16 years with only complaint of short stature. So if you all can appreciate in this photograph, she had all secondary sexual characters. She was she had menarche at an age of 14 years, and she was getting her menses regularly every month. So apart from short stature, practically there was no other complaint or no other marker in this child. She had no phenotypic markers of any syndrome, and she was absolutely a normal child, a slightly obese girl, but otherwise she was all right. And but since she was significantly, when we did our homework, when we took her oxological criteria, took the mid-parental height, and we plotted her on the growth chart, we realized that she is really short for her mid-parental height. So as the protocol, we need to always rule out Turner syndrome in girls with short stature. We did that, and to our surprise, we found she was, so see, this is the growth chart, and she was here, okay, and her mid-parental height was 155. So definitely there was a significant difference between the mid-parental height and this child's height, because her bone age was almost 16 years. So now there was no scope of growth left, but we had to find the cause of short stature. So we got a karyotype done on her, and this was a real surprise because this was not even a mosaic, and she was a pure Turner. So she was not even a mosaic, but still she had no phenotypic features of Turners. And then we had, along with that, we had done all the biochemical parameters, and her LH and FSH were very high. This is a case of short stature brought to me. So this was a boy who was brought to me with this deformity. And this was always treated like rickets for 1 to 2 years, and still the deformity did not improve, and it kept on increasing. That's why they consulted me. And then on detailed investigations, he came out to be a hypophosphatemic rickets. So hypophosphatemic rickets, I took a history of the other siblings, and if you see, this was the entire family. So mother had undergone multiple surgeries, and she also had the same deformities, but now post surgeries, she has started getting genu valgus. And these are the elder two siblings. So this is the elder daughter, this is the eldest daughter, but they actually consulted me for this boy. And on history taking, actually 4 patients were caught with this issue. And this woman would just keep getting surgeries done for correction, but actually her metabolic parameters were never corrected. So now these children also will require surgery because the deformities are very severe, and the elder one has already undergone 2 surgeries now. This picture is 1 year ago. After that, she has undergone 2 surgeries, and this girl is planning to get surgery done, and this boy is only on therapy. So now the pediatric orthopedic surgeon has asked to wait for him, but he's also one of the candidates for surgery. So this is another girl who was brought to me for short stature, severe short stature, and at the time she had tetany. And this tetany, so she was referred as an indoor patient with tetany, which was not resolving. So they were giving IV calcium. Whenever they would give IV calcium, her tetany would resolve. Okay, and then again after 2 hours, her tetany would continue. So for 3 days, she was on 4 times calcium IV infusion. But after the IV infusions, she would again start getting tetany. Her ionic calcium was very low. And then when they referred to me and I took her oxological criteria, she had also short stature, she had anemia, and then her calcium and all the parameters were low. So I got a celiac screen done for her, and she was celiac disease. So the malabsorption was so severe that anemia and all is seen. Hypocalcemia is also seen. But she had so much tetany, which was rarity. So I thought I should bring this case to the notice of all of you, that this child was. Then we started giving her active vitamin D and continued IV calcium for 3 days. Post that, her tetany started reducing, and 3 days later, then she was on only oral active vitamin D. Of course, celiac was to be taken care of, and now it's 6 months from celiac-free diet, and now she's doing gluten-free diet, and she's doing well. So she's the girl, if you all can see, she is severely anemic with no signs of puberty. She had significant short stature, and all the time, every time she was given iron, and her hemoglobin would improve. Again, after 3 months, it would come back to 3. So this repeated anemias should also give us a clue that there could be some malabsorption going on. This is one more girl who was brought to me for malabsorption, chronic diarrhea, and short stature. So she was brought to me for short stature. On history taking, she had associated diarrhea and repeated respiratory infections requiring antibiotics. So I got a cystic fibrosis genetic workup on her, and she came out to be CFTR positive. This is a child brought to me from some village in Uttar Pradesh, and this girl was brought with short stature, and if you see, she is 9 years old, significant short stature she had with multiple deformities, and this was a Muslim community and consanguineous marriage, and this was the third child, and the parents would say that this girl would repeatedly, after every 15-20 days, she would be bedridden for 10-15 days, and she would not get up from bed, complain of pain in the limbs, back, and then after 15 days again she would start walking. Again, after a few days, she would start saying that she had pain and become bedridden. So this was with deformities. So here you have to suspect any bony causes, and this was a case of osteogenesis imperfecta type 4. So this, actually I couldn't show you the eyes, but this photograph I had taken to highlight the blue sclera in cases of osteogenesis imperfecta. So this is her genetic confirmatory report of osteogenesis imperfecta. And this is her Z-score. So see, her Z-score was minus 4.1. And she had multiple fractures when we got the bone scan done, at least 4 fractures at a time. This is a patient from Kazakhstan, and we have these international patients coming to Max. So this patient was referred to me for obesity and undescended testes, and he also had short stature. He had sleep apnea. And if you all can appreciate, this child had severe obesity, truncal obesity with acanthosis. On genetic examination, he had bilateral undescended testes. You can see his limbs, the feet are so small, the hands were so small, and he had IUGR at birth. He was 1.2 kg at birth with feeding difficulties and sudden weight gain after the age of 1 year. So this was a case of Prader-Willi syndrome and genetically proven Prader-Willi syndrome. So here you can see this boy was short and obese. So the importance of plotting, whenever you do the plotting of these children, any child who is obese or short, whenever we plot them on the growth chart and we find that the child is short with obesity, you should always suspect an organic cause. Tall with obesity, it is generally nutritional. But short with obesity, endocrine causes are the commonest, and this child was a Prader-Willi syndrome proven on genetic studies. This is another Prader-Willi who recently came to the clinic. These are few cases during my fellowship that were very interesting cases. So this is a case. This is a case of Laron syndrome in siblings. And this Laron syndrome means they have growth hormone. The growth hormone is normal, but they have IGF-1 receptor issues, growth hormone receptor issues. So IGF-1 is low in these children, and they do well with IGF-1 therapy, which is extremely expensive. But now there are a few patients in India also who are taking IGF-1 therapy. This is a case of Russell-Silver syndrome. You can appreciate he was an IUGR at birth with triangular facies, little mental retardation, clinodactyly, atrophy. So one side is smaller, one feet was smaller than the other. So this was a case of Russell-Silver syndrome. These are a few success stories. So this is a girl with Turner syndrome, whom actually we started. So she's from Raipur, and we started her on treatment at the age of 12 years. So first time she was diagnosed as a Turner at the age of 12 years for short stature. Now the problem was that we did not have enough time, and we had to delay her sexual hormone induction. But luckily she did very well. We started her on growth hormone therapy, and then we did the sexual induction at the age of 13 to buy more time for growth. And now she's almost reached 4 feet 10 inches. So this is a real success. If we start treating them on time, they do quite well. This is another girl with short stature, and she had precocious puberty. So she had come to me at the height of 140 centimeters with first menses. And they took therapy with GnRH analogs and growth hormone for 2 years. And now she's 159 centimeters tall. So these cases are quite dicey when they come to us, at that time, to take a call whether to give them GnRH analogs and how much they'll benefit, because she was not a real growth hormone deficient child. But still, they were very keen on going ahead with therapy, and luckily she has done so well. So this I would really consider a success in terms of therapy, growth hormone therapy given in cases of precocious puberty. And this is a girl with congenital hypothyroidism with a free T4 of 0 on diagnosis and TSH more than 3000. And the parents were really worried that how would she do later on in life with this kind of a free T4. But luckily, because of screening, she was picked up on day 3 of life and we put her on therapy. Now she's completed 3 years and she's absolutely a normal child with normal speech, extremely cute and smart. So this is just to highlight that how treating children on time can give us very good results, especially in endocrine cases, we can get very good results. So with this, I would like to conclude my session with this last slide, that the red flag signs are whenever the child is below the 3rd percentile on the growth chart or above the 97th percentile, especially for precocious puberty, BMI more than 23 and 27 adult equivalent, movement of a reading across 2 percentile lines over a time of 6 months, any breast development in girls before 8 years, and axillary and pubic hair growth in boys and girls before 8 years. So I hope it was a fruitful session for all of you, and kindly put your questions in the question box, so we'll take it after the session.
Okay, ma'am. Now we will move forward towards our third session. The topic is case-based approach in SGA children. So I would like to warm welcome Dr. Hemchand K. Prasad. And he has done MBBS from Madurai Medical College in 2005 and MD in pediatrics from Madras Medical College in 2009. Then he has done postdoctoral certificate course in pediatric endocrinology from Bharati Vidyapeeth University, Pune in 2011. Then she did fellowship training in pediatrics endocrinology at Birmingham Children's Hospital as a part of SPE clinical fellowship program. Again, he did fellowship training in pediatric endocrinology and diabetes at St. Louis Children's Hospital, Washington University, as a part of Alan Durst clinical fellowship program of the SPED. Now, currently, he is practicing as a consultant department of pediatric endocrinology and diabetes at Mehta's Children's Hospital, Chennai. So now, warm welcome, Dr. Hemchand. Please, now you can take session.
Thank you very much. So I think over the next 20 minutes to 25 minutes, I'll be talking to you about a case-based approach to SGA children. So that's my disclaimer. And I thought I'll share these small stories which we have read and grew up. And this is the story of the 2 cats and the clever monkey, a stitch in time which saves 9, a copycat, a wolf in a sheep's clothing, and the conventional story of the rabbit and the tortoise. So why am I presenting all this? So over the next 20 minutes, we'll try to understand what SGA is all about, and as a pediatrician, what one can do to help these children. If you look at data on prevalence of SGA across the globe, this is a very beautiful slide, which clearly shows that with the improved care of neonates, the mushrooming of NICUs, the good level of neonatal care that is available, even at the primary care level, the prevalence of SGA, the survival rates of SGA are going to grow up. A byproduct of that is the endocrine problems associated with SGA are going to go up further. If you look at prevalence of SGA across different parts of our countries, the prevalence is very high, almost somewhere at 3.5% to about 25% of the babies are born SGA. Of course, this varied prevalence depends on the cutoff that is used, the chart that is used, etc. But still, the prevalence is significantly high. This is a chart which is taken up from the WHO and the Intergrowth, which shows us how head circumference, length, and weight should be measured in neonates. All of us as pediatricians are very well aware of this particular maneuver. And this is a summary of the growth charts that are available for identification of SGA. Of these, there are certain centers which resort to the usage of Fenton's chart, the new Fenton's chart, which is a meta-analysis of the growth curves of newborns from 6 developed countries, representing the data of about nearly 4 lakh neonates, including very preterm babies, and it is supposed to dwell very well with the WHO charts. But currently, I think the Intergrowth 21, the at-birth charts, which represents a subset of prescriptively grown neonates who are accurately dated and accurately sampled with a good representation from India, that is Nagpur, should be used. These are the inclusion criteria that were used to ensure that these babies were healthy both at birth and during the antenatal period. These are the Intergrowth at birth charts which should be used to classify and assess the growth of babies born in our country. So as a pediatrician, when you see a preterm or a term baby, please use the Intergrowth 21 at birth charts or the WHO charts if they are term babies to identify SGA babies. So this is the growth chart that is used for boys and for girls. And of course, there are a few criticism that is raised regarding the fact that there was a slight discrepancy in the growth parameters in India versus the other multicentric centers, and a high rate of preterm delivery was observed. But if you see the very beautifully, what is really observed is that the dwellability, the Intergrowth 21 and WHO kind of amalgamate with each other at term. So what does this mean? If you take care of mothers well at birth, during the antenatal period, babies are born ideally. A same concept that is reflected on the WHO charts. So I think the message from the slide is, please use the Intergrowth 21 at birth and identify SGA babies. Is it useful? Yes, this is an Indian study which shows that babies who are identified as SGA on the Intergrowth have more short-term risk factors. So the definition is either birth weight or birth length, or both below the -2 standard deviation for the reference population, which is the Intergrowth 21 at birth charts. So I think the clear message from this is what is reflected in the story of the Tom Sawyer. Do what you're doing, do it more meticulously, do it more properly, and think about what you're doing. Accurate measurement of anthropometry at birth, plotting the anthropometry on the Intergrowth 21 at birth charts, making the documentation of the infant appropriately as SGA, AGA, or LGA. So you need a proper chart, you need a proper cutoff, and you need a proper measurement of anthropometry. I think this is the first step in the optimal care of a baby who is born SGA. Identify it using a proper chart, a proper measurement, and a proper cutoff. I think that's the first message out of this particular talk. How should we feed these babies? These are some of the studies from various parts of our country who have described the catch-up growth of babies who are born as SGA. If you see the third study, it's an interesting study from the western part of our country, who have said that socio-economic factor and illness are two major confounders during the initial years of age. What does that mean? Babies who are born SGA and who are poor. Babies who are born SGA and have a major handicap during the initial years of growth tend to catch up slowly. I think this has to be factored while you are plotting, serially monitoring, and deciding to put them on growth promoting therapy. The second important study, which I think one should focus on, the baby catch-up growth of babies who are born SGA, is the delta WZ scores correlated with the body fat Z scores. What does that mean? If you push them to catch up weight rapid, that is, if you overfeed them, you're not only going to push their weight up, you're going to push their body fat also upward. It's a real point to ponder. You overfeed them, you try to push their growth comparable to a baby who is born AGA. The mother is happy on a short term and on a basis, but on a long term basis, the body fat Z scores rise up proportionately higher, putting this child at a risk of metabolic complications in the future. The consequences of rapid catch-up include abnormal body composition, abnormal markers, more rapid increase in the fat mass, higher visceral adiposity, and metabolic complications. So what is optimal catch-up? That's $1 million question which nobody knows the answer for. The only thing which can be told at this point of time is catch-up is an increment of 2 percentiles or a 2.67 SD scores should occur over a period of time. Rapid crossing of percentiles should be avoided, as emphasized very beautifully by Dr. Vaishaki's talk, that if you cross 2 major percentile lines in a short while, be careful. And that should especially be avoided both in terms of weight as well as height in babies born SGA. Aggressive growth monitoring, initially monthly, then 3 monthly, then 6 monthly. You have to watch for catch-up and please encourage breastfeeding as pediatricians. The important message coming again to this story, it is the clever monkey feeding the 2 cats. Identify those who catch up early, identify those who catch up late, identify those who do not catch up. Promote exclusive breastfeeding, avoid high-calorie dense food, give allowance for gestational age, use corrected age, aggressively growth monitor, don't overfeed, don't overfeed. Don't overfeed. I think that's the important message, the care of babies born SGA. Coming to the third concept. When do we initiate growth promoting treatment? These are the oxological criteria that are mentioned in the guidelines. They look very complicated. To make our work easy, the Indian Academy of Pediatrics have come up with the extended growth charts. So pediatricians who are running NICUs and taking care of SGA babies on follow-up should download these charts and have it in your well baby follow-up clinic. Measure the height and weight and plot it on these charts. And if you find the child's height below the minus 2.5 SD line, the child's height is below the minus 2.5 SD line, you are looking at a baby who is failing to catch up. And if the baby does not catch up beyond 4 years, be careful, this child may be a candidate for growth promoting therapy. So, pediatricians caring for NICUs with SGA follow-up, please use these extended growth charts for Indian children. Identify babies who do not catch up and start them on growth hormone after ruling out other treatable causes. These are some of the studies who have depicted the increment in height SDs, height catch-up growth in babies born SGA from Indian settings, and they have shown that there can be a good response of about 8 to 9 centimeters given over a period of 1 to 2 years. This is very, very important. This increment in height is not only short-term, but also long-term, resulting in an improvement in the final height. What is it that we are worried about as pediatricians is if we push the growth forward, are we going to push these children into metabolic complications? This is studied from various parts of the globe who are given a similar answer, very clearly says that no, they are not at a significant increase of metabolic complications. No reported case of diabetes, a positive impact on lean mass, improved muscle mass, reduced fat mass, improved bone mineral density, and a positive impact on body proportion. No significant adverse effect is noted. So the benefits of growth hormone therapy, a judicious use, I would say. Proper identification using the extended growth charts, improvement in the short-term growth, improvement in the final height, but no significant metabolic derangement. So be very, very careful and identify the child at the right stage and take the help of the right growth promoting therapy and push these child forward judiciously to have an optimal final height. A stitch in time saves 9. That is a message from this case. A proper measurement of anthropometry using the extended growth chart, early growth hormone therapy, and improvement of final height without any adverse metabolic complications would be the important crux which every neonatologist and pediatrician. So the message from this third story, Stitch in Time Saves 9, is please download the extended growth charts for Indian children and use it in your day-to-day practice when you're running your well baby clinics and following up these SGA babies. Now, what is it that we are interested in the long-term metabolic health of babies who are born SGA? This is a time bomb. The important message is these are the studies which have been done from different parts, long-term follow-up of babies who are born SGA from different parts of the country. And what all these 5 studies from different parts of South India, Western India, Northern India, Mysuru, Pune, and Vellore tell us is only one thing. Babies who are born light at birth and who are heavy at 8 years are at having adverse cardiometabolic profile. I repeat, when the pendulum shifts from one side, that is they are born light at birth, to go at the other end, that is they become heavy at 8 years, you're not only pushing their weight forward, you're also pushing their cardiometabolic health towards an adverse profile. So be careful. Higher truncal obesity, higher insulin resistance, especially those who have rapid weight gain, early adiposity rebound. Aggressive growth monitoring, measurement of waist, measurement of blood pressure, measurement of BMI should be done in every possible visit in babies who are born SGA when you're following up in them in your well baby clinic. I think the important message is what is shown in this. Don't compare the growth of a baby who is born term AGA and a baby who is born preterm SGA or term SGA. You cannot compare apples and oranges. You cannot compare a cat and a tiger. They are unique creations of God. Term AGA babies and a term SGA baby. Term AGA babies and a preterm SGA baby is different. Both are unique. Aggressive growth monitoring, monitoring of BMI on the WHO or IAP charts as per the age, blood pressure, waist circumference, all of these are simple tools that are available to you as pediatricians and neonatologists to identify babies who are going towards an early adiposity rebound and early adverse cardiometabolic health. Now, coming to the fifth scenario, this is a 7-year-old girl with early pubic hair, born as an SGA, rapid catch-up, metabolically obese. This hyperinsulinemia results in an advancement of body age and triggers the adrenal androgens, results in early puberty, which ultimately culminates in early puberty, short stature, fusion of epiphysis, and adolescent PCOD. Look at the chain of events. You're overfeeding a baby who is created thin. This triggers early puberty, which triggers early puberty, which triggers early fusion of epiphysis, which triggers adolescent PCOD. You have a short young lady with adolescent PCOS. There are some studies which report the usage of metformin. Of course, these are anecdotal studies who have shown that a trial with metformin can be helpful in retarding pubertal progression. Of course, more Indian studies and validation is required. But I think as pediatricians, these studies reinforce only one thing. We use the surrogate of metformin, which is nothing but exercise. Insist that these babies should exercise, improve their insulin sensitivity, and cause regression of the puberty. The puberty is something like a wolf in a sheep's clothing. The precocious puberty tends to tell you that this may be a case of early puberty, but actually it is a marker of underlying metabolic syndrome and hyperandrogenemia. As a pediatrician, exercise is something which you should insist in every SGA 15. Measure the BMI. If it is elevated, motivate them to bring it down. If it is normal, encourage them to maintain on the same profile. This is an important message from this particular case. Last set of information is looking at data on puberty in SGA. These are some of the studies from our own country who have looked into the onset, progress, sequence, and culmination of puberty in babies who are born as SGA. And what is it that they have observed? Researchers, both from our country and across the globe, have observed that the onset of puberty is early, the progress is rapid, the growth spurt may be attenuated, and they land up as short adults. I repeat, the onset is early, progress is rapid, and the spurt is attenuated. A reduced spurt, menarche, which occurs slightly earlier, rapid progression. So the message is early meticulous SMR assessment. Please follow the Indian Pediatrics recommended growth monitoring guidelines, including the SMR, and pick up babies who do not catch up and who enter into puberty early. These are some of the studies who have looked into a combination of GnRH and GH. That is, you block the puberty by giving GnRH and you push the growth forward by giving growth hormone. It's a very unphysiological form of treatment, but the response can be good if it is used properly. Dr. Vaishakhi mentioned about her case of a girl who presented with early puberty, whom she treated with combined GnRH and growth hormone, and she has observed an increment of about 19 centimeters. I think, Dr. Vaishakhi, you should report such cases, which is an eye-opener for all of us, that this combined GnRH and GH therapy is indeed useful in the appropriate clinical situation. So this is the data from Dutch group who have observed that when you give GnRH, the years of growth are prolonged. The window of opportunity of growth is increased, and growth hormone accelerated the growth during the window that is provided. You can see what is really beautiful is you can see the black line, the dark line, which is increased by giving GnRH. So when you increase the GnRH duration, you're prolonging the years of growth and adding more years for the child to grow, complemented by growth hormones. In fact, this is a consensus statement of the precocious puberty group who have said an addition of 6.6 centimeters, nearly 2.5 inches to the final height when you add the puberty blocking agents at the right time. So I think this is very important that we use it in the right situation in girls who enter into puberty, who are born SGA, and who are short at the onset of puberty. I think to understand this, I think there can be no better story than the story of the rabbit and the tortoise. The rabbit is a typical case of an SGA baby who enters into puberty early, progresses rapidly, has an attenuated growth spurt, early menarche, and loses the race. Usage of GnRH analogs slows down the pubertal progression and converts the rabbit into a tortoise and adds 6.6 centimeters to the final height. I think the message is, please use the combined treatment judiciously, the right situation to add to the final height. Before I go into the take-home messages, a quick bit of tidbits. Are SGA and IUGR synonymous? No. IUGR is a serial. It's a longitudinal assessment, including intrauterine growth. SGA is a cross-sectional assessment. Which SGA is less likely to catch up? Those who are symmetrical, those who have length affected more than weight. How long should one wait for catch-up? 4 years. Is there any difference between term SGA and preterm SGA? Yes, a double whammy. When you are a preterm, you're both less in gestational age as well as weight. So the catch-up is reported to be lesser. Should metabolic profile be checked in all babies born SGA as you're following now? No. Growth monitoring. I think that will give you the clue. When your BMI is elevated, when your waist circumference is elevated, when your blood pressure is elevated, you check for metabolic risk factor. Should you check for cortisol? No, not on a routine basis unless there is a clinical suspicion. Before I go in for the take-home messages, these are 2 books that have been authored by our team. This is the IAP textbook of pediatric endocrinology produced by the father of growth, Vaman sir. co-edited by me. This is a new textbook written for postgraduates by the postgraduates in pediatric endocrinology, an exam-oriented approach which can be purchased online from the Paras website. These are 3 mobile applications on pediatric diabetic ketoacidosis, Diavoc, and Obesiago for management of obesity, type 1 diabetes, and DKA. Available free for download on the Google Play Store. Please download them and use it for the benefit of your patients. This is an article on SGA which we recently wrote in the Indian Journal of Practical Pediatrics. Please read them up if you have time. And this is a handbook on growth assessment and growth disorders exclusively for pediatrician, which is applicable today. I will be happy to provide an e-copy of this handbook. Coming back to the golden stories which we all grew up with, the Tom Sawyer who painted the fence again and again. I think it reinforces that all neonatologists and pediatricians should again and again train themselves, get into the practice of measuring the length, weight, and head circumference at birth, plot it on the Intergrowth 21 charts, and identify them as SGA, AGA, or LGA based on their growth parameters using a proper cutoff. The second story of feeding, giving the right amount of feeding to the right child. It's very important that catch-up be optimized. Don't overfeed them. Exclusive breastfeeding. Avoid high-caloric food. Give allowance for gestational age. Use corrected gestational age for growth plotting. Identify those who catch up properly. Identify those who catch up rapidly. Be careful. Identify those who do not catch up. Be careful with them as well. And identify those who do not catch up and refer them for growth promoting therapy. The message is aggressive growth monitoring in every available opportunity. The story of the stitch in time that saved 9. Either use the Intergrowth, use the growth, extended growth charts for Indian children. Identify children with height below -2.5 Z-score line. Refer them for early growth hormone therapy. Improved final height should be emphasized to the parents. Don't compare the apples and the oranges. Don't compare the growth of the term AGA and a preterm SGA or preterm AGA baby. Rapid weight gain during childhood is detrimental. So blood pressure, waist, BMI should be measured at every available opportunity. Early puberty in an SGA baby may be a sign of precocious puberty. Rapid catch-up, metabolic syndrome, hyperandrogenemia should be identified early. Remember the story of the rabbit and the tortoise. Children who are born SGA can enter into puberty early. They may have a rapid progress, attenuated spurt, and early menarche. Judicious use of GnRH analogs and improved final height should be considered in a case-to-case basis. Thank you very much for your patient hearing, and I hope this presentation helps us to identify and manage SGA babies to give them a better and improved long-term health. Thank you very much.
Thank you, sir, for nice presentation. Now, I would like to invite all the 3 speakers for Q&A session. Please join us, Dr. Vaisakhi and Dr.
Thank you, Hemchand. It is always a treat to listen to you. And Vaisakhi, your cases, what you presented were wonderful. I mean, they are really eye-openers and we learn so much during our practice. While we are practicing, we are still learning. And we should quickly go to the question answer session. We have few questions in the chat box. Can growth be plotted in any mobile application? This is one of the questions. So have you come across a mobile application? The IAP mobile app is there, and can we plot growth in that? Hemchand, if you can take that question.
Yeah, I thank you. I think the IAP growth chart app is available for free download both on Apple and Google Play Store. Developed by the Indian Academy of Pediatrics. All you need to do is enter the date of birth, the sex, and the anthropometric measures. It gives a visual position of the child on the growth chart. Less than 5 years on the WHO chart and more than 5 years on the IAP chart. If it is downloaded on the parent's mobile, probably it allows you to serially monitor the growth as well. because I think the app is so developed that the data is stored within the memory of the phone itself. So I think that should be emphasized to all educated parents to look. And they, as expected, they are very beautifully color coded as well, so that the coding of the yellow sign and the red line for growth abnormalities is beautifully done, so that they understand the direction of growth and how aggressive they have to be.
Yeah, thank you for that answer, Hemchand. One question for you, Vaishakhi, about growth hormone. How safe is growth hormone? And if at all we are expecting some side effects, or we have to explain it to the parents, what side effect we should explain? And how do we monitor a case of who is on growth hormone therapy?
Okay, thank you, Dr. Hari, for the question. So see, that way, growth hormone therapy is a pretty safe medication, but a few side effects we always explain to the family before we put the child on therapy. Commonly seen side effects are mild headaches, because growth hormone causes little bit of water retention. Especially this is more common in children who are growth hormone deficient, because when they are hit by the growth hormone given to them initially, there is a little bit of water retention which can cause mild headaches early in the morning. They can also have edema below the eyes when they get up in the morning. Again, this is because of water retention. But within 15 to 20 days, the body kind of gets used to this growth hormone, and then this side effect of mild headaches and water retention goes down. The other side effects that have been mentioned are slipped capital femoral epiphysis, which I have not yet seen ever in a patient taking growth hormone therapy. But yes, during my fellowship, I had seen one patient, and this is generally seen in children who are obese, who have a rapid gain in height, and especially in growth hormone deficient children. So if whenever we put them on therapy, we always tell them that if there is sudden pain in the hip joint or the knee joint and the child is having a limp, then they have to immediately report to us. Another side effect is if there is already existing scoliosis, it can worsen when given GH therapy. The reason being there is a rapid growth, so that will itself aggravate the scoliosis and the kyphosis in the child. So before putting the child on growth hormone therapy, be it whatever is the indication, we always check for any scoliosis that is present in the beginning of the therapy. And whenever we see children on follow-up on GH therapy, it is important that we do a examination for kyphoscoliosis. Now regarding, so these are generally the side effects that we mention to the patients whom we are going to start growth hormone therapy, and we have to monitor them in the form of, when we are monitoring these children on therapy, we have to keep taking their observological criteria. We have to do their Tanner staging, that is a sexual staging. And generally their IGF-1s should be monitored at least at 6 monthly intervals, because we need to keep them in the range as per the IGF-1 charts. If they are going beyond range or they are below range, we can titrate the dose accordingly. So that's how IGF-1 monitoring would help. I think that completes my question.
Yeah. Thank you, Vaishakhi, for that answer. One question again, I would like to ask Hemchand regarding syndromic short stature. I mean, those who are proportionate and asymmetrical short at birth, and then they fail to catch up. How the growth hormone changes their life. I mean, how early we can start them on growth hormone, or shall we wait for 4 years, or is there any experience in starting them early? Your take on it.
Yeah, I think as far as SGAs who are born in syndromic SGAs, so to say, I think we should definitely keep in mind that they are an important group of children who would be benefited by growth hormone therapy. So I think the timing of growth hormone therapy should be individualized. If you see the guidelines, the Western guidelines, which we tend to follow, the American guidelines are very pushy in the sense that they tend to recommend growth hormone from 2 years itself, whereas the European guidelines are more liberalized, and they say wait till 4 years of age to optimize catch-up. So having said that, I would say on a practical note, One would be just in a country where the spending on health comes from the patient's own pocket in majority of the settings. I think it would be judicious for them to wait till for a while till they to see if they spontaneously catch up or they do not catch up. And the other important thing one should be having in mind is the a cutoff age of 5 years, because that is an age where you have the transition from the WHO to the Indian Academy of Pediatrics, and the Indian Academy of Pediatrics represents the growth of Indian children. Although there is the WHO charts also had a good representation from the affluent Indians, I think there is enough anecdotal studies to tell us that there is an overdiagnosis of growth faltering using the WHO charts. That is, the sensitivity is high, but the specificity is very poor. They tend to overdiagnose, and in fact, there is a lot of currently available newer charts that are being developed for children below 5 years of age, etc. So I think one would be justified in waiting for 5 years to see if they catch up or not. But one should be careful regarding clinical pointers to syndromes like Russell-Silver syndrome, etc., who are in themselves licensed to take growth hormone therapy as well. So I think an individual case-based approach should be considered. 5 years may be a practical cutoff because one goes into the IAP charts, IAP data while interpretation of axology at that point.
Yeah. In continuation of that, Hemchand, if an SGA is again showing faltering of growth on serial measurement, not catching up, but faltering, what are the possibilities we should look into in SGA?
Right. I think the conventional ICP model of growth should definitely be considered, including an SGA, where the growth and is dependent on infancy during the initial years of life, and hormones during the second phase, and sex hormones during the third phase. Whether the SGA baby is I think an SGA baby is like a seed that you plant and see if waiting for the fruit. That is how I would say catch up in an SGA baby would be. One would think whether the soil is fertile, one would think whether there is adequate manure, one would think whether there is adequate rainfall, etc., whether the seed is potent. Similarly, look for any underlying diseases which is preventing this child from growing. There may be a silent RTA, there may be a silent celiac, which is responsible for growth faltering. A systemic disease has to be ruled out. Very importantly, you should also ensure the caloric intake, whether the child is receiving adequate calories, age-appropriate calories, nutritional supplementation is adequate or not, the protein supplementation is adequate or not, should be inquired into whether the child is getting adequate nutrition. And of course, endocrinopathy. There's nothing that prevents an SGA baby from having growth hormone deficiency as well. So these kind of, that may be preventing this child from catching up. And very importantly, the dose for replacement would be very different would be very lesser in the baby who has a growth hormone deficiency compared to a child with SGA, where you would be replacing growth hormone in a growth hormone sufficient child. So all these factors should be kept in mind in a baby with an SGA who is faltering and optimized before considering growth promoting therapy.
Okay, thank you, Hemchand, for that. Vaishakhi, one question for you. I mean, India is a huge country, and we have got so many climatic changes. We have got rural-urban divide, and so what are the causes of short stature? Is it area specific, or how it can be deduced from rural India? The cause is different from urban India, or the cause from Jammu Kashmir is different from whatever the causes we see down south in Chennai and somewhere. And do you have any input in that regard?
So, see, primarily what I see in my clinic, the commonest cause of short stature in girls is mainly hypothyroidism that I have noticed. And in boys, it is constitutional delay in growth and puberty. So organic causes are rare, and only about 4 to 5% out of the entire lot of patients who come to me for short stature, I'm able to find an organic cause for short stature. Some are actually not even short stature, they're fitting into auxological criteria of short stature. Okay. So, and apart from that, I have basically practiced in Maharashtra, and then I am here in North. What I see is that in Maharashtra, there is a lot of consanguinity in the West. Karnataka side, Maharashtra side, there is a lot of consanguinity that could cause some genetic causes of short stature, which are rare though. In North India, there is no consanguinity at all. So not even in the Muslim community do they have consanguinity in North India. But in North India, people coming from Uttar Pradesh, Bihar, there is a lot of malnutrition that I see as a cause of short stature, anemia, malnutrition. And here, celiac is very common because celiac disease as a cause of short stature is very common because here there are primarily in North India, they are wheat eaters. So this is what I found different from the West. However, I have no clue about East and South that Dr. Hemchand could point out to. But these two places, at least because I practiced for 7-8 years in Mumbai and then I have come to Delhi for 10-12 years. So now I'm able to correlate. There are some differences between the causes. So this is what I would say about the geographical and the rural-urban difference.
Yeah, thank you, Vaishaki, for the answer. And any inputs, Hemchand? Finally, you want to put some?
No, I think if Madam has said everything. So if you look at the causes of short stature that are published from various centers across our country, they largely uniformly say the same thing. Normal variant short stature is the predominant cause, even in an endocrine clinic. So I think that has to be kept in mind, that normal variant short stature, familial and constitutional and nutritional deprivation, and systemic disease is indeed common in every center. They reported. AIMS recently published in JPEM, then BHU has published in IJP, Vadia has its own data. So every big center, if you see, they say the normal variant is the predominant. Endocrinopathies kind of narrowed out, even in a specialty clinic. That is one thing. And as you rightly pointed out, celiac disease being a disease of beyond the topic of cancer and being less prevalent in the southern part of the country should definitely be, but it's there here as well. So that is there, and you spoke very well about the consanguinity being there. So I think, yeah, so all that definitely should be borne in mind.
Okay, thank you, Hemchand, for the answer. And I would like to thank both Vaishaki and Hemchand for enlightening us on this topic of short stature, SGA, and the wonderful cases discussed by Vaishaki. So I would like to conclude here, and I would like to invite the Pfizer team to take over.
Yeah, thank you, sir. Entire session was very nice. So on behalf of Pfizer, I am immensely thankful to all the three eminent KOLs for interactive and insightful discussion with clinical experience, which will helpful to cascade knowledge to patients through pediatrician or neonatologist. And apart from that, I also extend thanks to all the participants, whoever joined this meeting and manage your valuable time from your day-to-day clinical practice. Thank you. Thank you, sir. Thank you, participants.
Thank you. Thank you, everyone.
Thank you, everyone. Thank you, Dr. Hari. Thank you, Dr. Hemchand. Good night.
Yeah, good night. Signing off. Bye-bye.
Thank you, doctors. Bye, sir.
Rugaya, please conclude this meeting.
Yes, sir. Thank you, sir. Bye, sir.
Thank you.